Welcome here. It's a good turnout. Thanks for coming. I know some of you, and others I don't, but that's great. Welcome to Coordinated, and it's a kind of a cold November night, and I'm glad you all came out despite that. The presentation will be brief. The plan will be to briefly talk about knees as a little bit about knee arthritis, and then there'll be time, I'm sure, for a question and answer period. So we'll be around, okay? So first off, knee replacement. The anatomy of the knee, the knee is the largest joint in the body. It is a hinge joint. Talk a little bit about the anatomy. It is a hinge that allows for flexion and extension. Is there a pointer here? No. And also allows for rotation. So it has a little bit of, it allows for the knee to extend or straighten, flexion or bend, and then translate or glide. There's three major bones that make up the knee joint: the tibia bone, the femur, and the patella. And it's estimated 70 million patients in the U.S. Have some form of arthritis. Not necessarily the knee, but certainly that's probably a little less than a quarter of the population. That's a very conservative estimate. And there's many forms of arthritis. There's osteoarthritis, which is the most common form, and that's basically a wear and tear, and it's something that we really don't know exactly why it happened. There's a deteriorating of the cartilage, and ultimately the bone underneath the cartilage over a period of time. It's a degenerative condition. Generally doesn't improve. We can improve the symptoms without surgery, but we can't change the process or deterioration of the cartilage. Rheumatoid arthritis is an autoimmune disease. It's a very complex process, and it is a much smaller portion of the population. It presents many times earlier in life than osteoarthritis. Affects multiple joints, and again, is a much smaller portion of the total arthritic population. And then there's also osteoarthritis can be secondary to many reasons. Post-traumatic, after a knee injury, such as an ACL injury that has never been repaired, or after a major cartilage injury. So and it also can occur after an infection, which is extremely rare, and there's other forms. So what's causing your knee pain? That's really what people come and ask me on a daily basis. They really, why does my knee hurt? And a healthy knee, it looks like this. It's the femur and tibia are gliding on two cushions called the menisci, and the cartilage on the knee is giving them that glide. And it's a very frictionless system that has been developed over time for us, and it's much more. The coefficient of friction is 1/10 of the friction of ice on ice. So a normal knee just has a wonderful glide, and in arthritis, there's a breakdown in the cartilage, breakdown in the cushion or the menisci, those two shock absorbers between the femur and tibia, and ultimately a breakdown of the cartilage on the bone. And it is that wear and tear and that deterioration that causes the knee to inflame and those pain fibers to set off a chain of events that is very uncomfortable. And mild arthritis is well tolerated by many people, but it's that when that process becomes moderate to severe that I end up seeing a lot of you. So, and a lot of people want to know, when is it time to see your doctor? When is it time to be assessed for knee pain. And really what it comes down to is knowing, what your activities are and are they being affected dramatically by your knee pain. So does the knee hurt for prolonged periods of time? Is it waking you up at night? That's a form of arthritis called osteonecrosis. Often night pain causes that, and that needs to be assessed. Is it painful to walk and do your normal activities of daily living, like shopping or just walking recreationally? Are you taking over-the-counter pain medications that just aren't working? And if you're taking more of them, are you starting to take more ibuprofen or more Aleve? Is it affecting your daily living in terms of your activities, such as a sporting event or just going to things? Are you changing your lifestyle because of pain in your knee? That's when it's time to have that looked at. It's time to seek a medical or specifically an orthopedic opinion concerning what's going on with your knees. And have you gained a lot of weight with your lack of activity? That's another important consideration. So these are all considerations of when it's time to see your doctor concerning your knees. And again, this is just a slide assessing your pain. This is these are the activities that may be affected by knee pain or by osteoarthritis of the knee, by bending and stress on the hips and knees, by walking and prolonged walking. Is that causing you pain? Are you changing the amount you're walking? Do you have pain while driving? Are your sports, like the activities you enjoy, such as tennis or golf or skiing, are you unable to really, have you changed the things that you do because of your knee pain? It's an important consideration. So that's a little bit about the things we look for and what osteoarthritis is. Osteoarthritis is not, the treatment for osteoarthritis is not just a surgical option. As orthopedists, we treat our patients operatively and also very much non-operatively. And as many of you know who have visited an orthopedist, a good orthopedist will try conservative options in many respects unless the indications for surgery are just too significant, too apparent. And what are some of those non-operative options? Well, we want to try to decrease the inflammation of the knee, and that can really change modify the symptoms and make you feel more comfortable. One of those is using a steroid injection. It's still a very acceptable way to approach this. It's not something that you do over and over, months and months and months, but the judicious use of an occasional intra-articular steroid injection can give you some relief. It's not the use of it, it's the abuse of it by some physicians. So injections work. The other option is oral analgesics, or such as Tylenol, ibuprofen, or one of the prescribed anti-inflammatory medications. We very often do not use narcotics for treating arthritis. We use narcotics for treating pain after surgery, and that's really what, as most orthopedists use something such, a narcotic, but we don't use that to treat arthritis pain. The use of hyaluronic acid is such as, you may have heard about this medication. It's just to summarize in a basic way, hyaluronic acid is a family of medications called hyalurons, and they are basically an inert substance that we've developed synthetically to inject into the knee to give a little cushion to your knee, a temporary cushion. It doesn't replace cartilage, but it gives a little cushion to this area, a little bit of a shock absorber effect on a temporary basis. It can last for months. It can be ineffective. It can work for 6 months. It can work for a year. Some patients haven't returned to see me never again. It's not a panacea, but it's something in our armamentarium. It's something we use to try to treat a patient non-operatively if that's their desire. And it's really a decision you make with your orthopedic surgeon or rheumatologist. Physical therapy. Physical therapy is a very, very good way of treating osteoarthritis. It's not, again, it doesn't work for everyone, but regaining the motion in your knee and working on the strength can improve the biomechanics of your knee and very much modify your symptoms. And that's what we're doing. It's not going to improve or reverse the osteoarthritic process, but it certainly can help you feel better and modify your symptoms so that you can go about your normal activities, or at least improve on your activities. Knee replacement is a surgical option for the osteoarthritic patient. Many times, knee replacement is an option, and in some circumstances, there are some surgical options that preclude or that we would use before knee replacement, such as an arthroscopic debridement. And there's some controversy, but for the significantly arthritic knee replacement clearly makes sense. And what does that do? Knee replacement, you're not really removing the knee, you're resurfacing the knee, much like you would crown a tooth. I use that analogy in my office all the time. And it just, by resurfacing the knee and changing the alignment back to the normal mechanical alignment that you were born with, or close to what you were born with, it relieves the pain, restores the mobility, gives you back that cushion that you're missing. So you're not actually cutting the knee out, you're really just resurfacing the damaged cartilage. And there's very minimal bone loss on a knee replacement. Knee replacement surgery is very beneficial if it's used in the right circumstances. It's for the patient that truly has the arthritis that warrants that procedure. It's not indicated in my practice for the mildly arthritic patient. But 500,000 people received a knee replacement this past year in the United States, and that's a lot of people. I think when I finished my residency, maybe 60,000 people had a knee replacement in 1989. But that's a significant change. So, why do more people need knee replacements now? The population hasn't changed significantly. It's increased, but I think people are more active. There's a lot of epidemiological reasons why there's been such an increase in knee replacement patients. But given that fact, there still is a very high success rate from a knee replacement. It runs around 90 to 95%, which is significant. That means that for the most part, the orthopedic surgeon is making that decision appropriately for his patients in the United States. And they're not being done inappropriately. And the average age of knee replacement surgery has gone down significantly. I think it's dramatically, as much as a decade, the average age is up at least 10 years younger than it used to be 15, 20 years ago. This is what a knee replacement looks like. It is, again, a surgical procedure to replace the diseased cartilage on the femur and the tibia. So you're actually crowning the femur and tibia. You're putting a stemmed component, for the most part, into the tibia, and then you're putting a little bit of, and the polyethylene liner, which is this little spacer, is giving you back that space that you've lost. It gets that diseased cartilage, and that narrowing of that joint space is then corrected. And that's, there's many knee replacements out there. This is a very good one. And really, I'm of the belief that it's not necessarily the knee replacement that you have, but the surgeon who puts it in. And how does it work? Again, you're removing the diseased bone from the tibia and from the femur. You place this polyethylene insert in between, and then some patients have a patellar replacement too, depending on the amount of arthritis of the patella. And that's a surgical decision. Some physicians resurface the patella all the time, and some do it just when the arthritic process is so aggressive that it warrants it. And that's really what a knee replacement looks like today. This is a good shot. I like this picture because it shows a healthy knee on the left, and it shows that joint space that the arthritic patient is missing, okay? And if you have a bowed knee, like a varus knee or bowed knee, you're going to have that narrowing on the inside. And for my patients who are knock-kneed, have that knock-knee, valgus knee, their narrowing is going to be on the outside. But nevertheless, a knee replacement restores this alignment and gives you that space back where you're missing it. And I always show my patients their pre and post-op x-ray so they can, it helps them, I think, in physical therapy when they see the difference. And there's some, and I really don't want to get into the nature of what knees you use. There are some knees that rotate a little bit, some knees that are fixed, meaning that the femur rotates on this, but this piece, this polyethylene, does not rotate on the stem. But the research is, honestly, what the research out there is more, it doesn't substantiate any particular knee. More or less, it's really the technique of the surgeon that I think really matters. I am a big believer that physical therapy after knee replacement is extremely important. If I think that a patient is unable to complete physical therapy after knee replacement, I really do not, I dissuade them from proceeding with that procedure. I really do. It's very, very important that because I'm very proud of my results, and I really, if a patient can't do the PT afterwards, they're not going to have a good result. Again, this is if you break down the knee replacement, the femoral component, the polyethylene insert, the tibial component. Basically 3 components plus the patellar component. They're all customized. Every one of these pieces or components has multiple sizes, multiple thicknesses, and some have constraint built into them, some don't. It really is dependent on the patient's needs. So you really do get a custom knee when you add it all up. You have, 10 different femurs, 15 different polyethylene inserts. It really does become quite customized. I did want to talk briefly about partial knee replacement because it is still part of my practice. I would say it's about 2% of all the knee replacements I do, which is a very small part. But I use it for a patient who's in their 40s, maybe early 50s, who has just a little bit of arthritis. I mean, only one side of their knee, 1/3 of their knee, has has a diseased or arthritic portion. The outside of their knee has to be normal. Patella femoral space has to be normal. Their ligaments have to be intact, and they have to have pretty good range of motion of their knee. For that patient, we do a partial knee replacement. I consider it a much harder procedure because basically you're leaving 2/3 of the knee intact and resurfacing 1/3 of the knee. So you're asking the body to really kind of, it's tricky because you're balancing and it's just a little tricky when I consider that for just a small portion of my patients. And this is what it looks like. This is a partial knee replacement. This is that little femoral component. This is the tibial component. This is what a total knee replacement, and you can see the difference. It's a very different procedure. This is what a partial knee looks like on x-ray, and this is what a total knee looks like on x-ray. And they're, again, very, very small indications for this procedure. I think, though, it is a very good tool to have for that 45-year-old active, recreational athlete that really who has 2/3 of their knee quite normal. And, I'm sure that there are people right here in this audience today that are just kind of wondering, are they ready for a knee replacement? And you have to assess, your ability to function. And I think that as your treating orthopedist, I should be, I can help guide you in terms of making that decision. And you have to ask, is your pain and loss of function affecting your quality of life? I don't want my patients to come in a wheelchair to have a knee replacement. That just makes no sense to me. You're so deconditioned that you'll do poorly in physical therapy and you'll have a mediocre result. So when you have a knee replacement, you want a good orthopedic surgeon is going to be able to help you decide the appropriate time for that. And it's when the pain is just not worth it anymore, you're not having fun anymore, your quality of life is decreased, you're taking too much ibuprofen and you're just uncomfortable. But you don't want to be so wasted, so deconditioned that you're not going to rehab properly. And really, and you have to, and that decision has to be made with your physician. And again, this is just what I have alluded to, and that's that that these results, that joint replacement is extremely rewarding. In most of my patients, I have they're very pleased with their knee after they've done their therapy and they've let it heal. There's risk to any surgery, but I think that with proper rehabilitation and a well-placed knee, you can have an excellent result. And that decision for knee replacement has to be made, again, with your orthopedic surgeon. So in summary, Osteoarthritis is the leading cause of knee pain and degenerative arthritis of the knee. Osteoarthritis is degenerative. It doesn't get better, but you can make it better at times and feel better, even though the condition itself may not improve in terms of the actual deterioration of the cartilage. Early diagnosis and treatment is very important because some patients don't need surgery for a fairly long period of time. And knee replacement in the really arthritic patient can be much harder in some patients than in others, because we get some patients that really should have had their knees replacement a full 10 years prior to when we see them. And those become much harder procedures with much more surgery, much more types of more constrained prosthesis put in. It's a much harder procedure. But if you weigh it all at the end, 95% of our patients, 90 to 95% is a good number, are quite satisfied with their knee. And I'll be around afterwards for any questions you may have, but Dr. Weiss is going to talk to you right now about total hip replacement and arthritis of the hip. Thank you.
Evening. I'm going to try to be a little bit brief and not replicate anything that's been said before. My job is to talk about hip replacement tonight. And in a way, it's a little bit easier to determine when your hip needs to be replaced than it is your knee. Because you can substitute a lot with a stiff knee. You really can't with a stiff hip, because a lot of times there's difficulty sitting, there's difficulty climbing, there's difficulty sleeping. So what we're going to talk about initially is, how a hip works, what the basics are, and what to look out for if you think it's time for a replacement. All right, the anatomy of the hip's a ball and socket joint as compared to the knee. It's got a relatively deep socket and a fairly good ball, good-sized ball, that's got ligaments that hold it in position. There's a lot of reasons for a hip to wear. Some is that the socket is shallow. Some is that the ball doesn't develop properly when you're a child, and some is just from trauma. All these variety of reasons will cause wear of that cartilage on the end of the ball. Now, we already talked about the osteoarthritis and the inflammatory types of arthritis, so I'm going to skip over that. There's a high satisfaction rate for hip replacements, and I would say the biggest difference between hip replacements and knees is that they're much less rehab dependent. If you do a perfect knee replacement job and you don't go to therapy, you're going to get a bad result. If you do a good hip replacement and you don't go to therapy, you get a good result. Okay? It may not be an excellent result, but it's not anywhere near as therapy dependent. We'll move on a little bit. So, healthy hip has a nice smooth gliding cartilage on the end of the bone on both sides of the joint. The diseased hip loses that cartilage just as it does in the knee, and you have a rough surface that catches, that grinds. Now, the one misconception I want to leave everybody with, or get rid of tonight, I should say, is that when people say their hip joint, they usually feel back here. Your hip joint is in the groin. When people schedule, and they come in for hip pain, 9 times out of 10 it's back. When they come in for groin pain, that's when it's hip arthritis. So if you have pain in the groin or buttock pain, that's the hip. If you have pain back in here, that's your back. All right? And hip manifests itself different ways. Difficulty tying your shoes, difficulty taking high steps. You may have a significant limp. A lot of people, when they walk, will try to unload that hip. When they walk, they'll try to shift their weight over top of it so that they don't put that bending force across the hip joint. One of the first things that people tend to notice, though, are the difficulty in tying their shoes, sitting on a low chair, sitting on a toilet, those type of things. And again, non-operative treatment consists of the anti-inflammatories. Injections in the hip are difficult because it's not a subcutaneous joint. It has to be done under X-ray, and in certain circumstances can be successful. Viscosupplementation that Dr. Godbout talked about isn't approved for the hip, and therefore not an option. And then again, physical therapy in early stages of osteoarthritis can improve your range of motion and decrease some of the compression across that joint. and get you farther down the road before you need a replacement. So there are two different types of hip replacements. One is a resurfacing, in which you keep the normal femoral head and you just put a metal cap on that and a big socket. And one is the traditional hip replacement. The resurfacings have come under fire as of recent because there's a fairly high failure rate, about a 9% initial failure rate because of the loss of blood supply to that bone, and about a 15% delayed failure rate. So the incidence of those being done in the United States is decreasing, as we speak. So what does a hip replacement consist of? Well, as opposed to the knee, which is just resurfacing, in this case, what you're truly doing is that you're cutting off the diseased head and neck area and replacing that with the stem that goes down into the femoral canal, which has porous coating. And what happens is the bone then becomes adherent to that, and it becomes a dynamic interface. It's an interface that constantly repairs itself. In situations where the bone is insufficient, and that's probably now less than 5% or less in the United States, you have to use cement. But cement, like cement anywhere, fails eventually. So we've moved away from that. I would say 95% or more of all hip replacements are done without cement. Similarly, the socket. What you're doing in the socket is that you're reaming into the normal bone, getting rid of the diseased bone, and putting a metal cup in there that again has a porous coating. And I encourage you to look back at the table and you'll see what the surface looks like. Initially, we'll use screws oftentimes to hold that in position until the bone grows into it. But again, that's a dynamic surface that constantly breaks down old bone and builds up new bone and constantly repairs itself. And then you have an interface between a ball and the liner of that socket. Anybody who's read the paper understands that the lawyers love that interface because there has been one type of interface that's recently been recalled. And that was a design, I think, in which people thought bigger was better. Initially, the size of your femoral head is 50 millimeters, 55 millimeters, etc. The old hip replacements that we used balls that were 28 millimeters or 32 millimeters. Well, what you trade off there is stability. The larger the ball, the better the range of motion, the better the stability. So we went to the 36 millimeter balls, 40 millimeter balls. Well, to do that, you needed an interface, a surface that didn't wear. So when we went to metal on metal, that allowed us to use a thinner interface and therefore a bigger ball and have all those advantages of stability and range that we didn't get with the smaller balls. Well, if people said, well, if those balls are pretty good, why don't we go to even larger? Well, what happened is with the even larger balls, you used a smaller socket and ended up getting some edge loading and getting some metal wear, and you had about twice the failure rate of normal hip components. Well, that's DePuy, which was the company that had designed that, was very diligent in recalling those and making compensation to the people that had that type of component. But unfortunately, it condemned a lot of the other metal on metal components which were working very well. And we can discuss that in the question and answer a little bit later. So this is a pre-op x-ray. You can see that the cartilage, the nice smooth cartilage interface, is completely worn away. And when the body sees increased stress, it reacts by making more bone. That's what bone spurs are. This is the normal reaction of osteoarthritis. A hip replacement changes that interface and gives you a pain-free interface with metal on plastic, metal on metal, ceramic on plastic, and we'll discuss that in just a little bit. Let's just move on here. All right, so the bearing is what we're talking about. We're talking about that interface that fits into the cup and that the ball sits on. The options are metal and plastic, and that's been around for 25, 30 years. And the problem with that is that the plastic wears. Metal obviously is a lot harder than the plastic, and so you get plastic debris, which early on caused inflammatory processes and caused erosions of the bone. We've improved that plastic right now to the point where it wears about 1/10 to 1/100th, depending on how it's treated, what the old plastic used to wear. So a lot of those issues have gone away. The metal on metal, the obvious advantages of that are that it allows you to use a bigger ball because you can use a thinner interface here. And as we said before, the advantages are better range of motion, better stability. The ceramic on ceramic has pretty much been condemned because of what they found early on was about 10% of those had a squeak, just like a squeaky door. Unable to predict who that was and who was going to occur in. But obviously that's not something that you want to have. So ceramic on ceramic has sort of fallen by the wayside. And a lot of people move to the ceramic on plastic as another alternative. The ceramic head not being as hard as the metal and the plastic being improved, we think that the wear characteristics of that are going to be intermediate between the metal and plastic and the metal and metal. So those are the interfaces that are currently available. So, in summary, hip osteoarthritis is the leading cause of hip pain. It can be fixed by a hip replacement. There's other non-operative treatments that we try first. And again, if it hurts back here, it's your back, go to the back surgeon. If it hurts in the groin, it's your hip, and we'll be certainly happy to take a look and counsel you accordingly with that. Yes?
Do you use the anterior approach in any of your hip replacement?
Yeah, there's basically a number of different approaches to the hip. There's anterior lateral, there's posterior lateral. Okay, and they all have advantages and disadvantages. One of the biggest disadvantage of the posterior hip approach, which most people use, is the potential for dislocation. And that occurred particularly with the smaller balls and larger individuals. So the anterior approach doesn't disrupt that posterior capsule, but it puts you at risk for anterior dislocations. All right, and it doesn't, from a visualization standpoint, you need special tables, special instruments to be able to do that. So there are people in our practice who use anterior approach. When I trained in my residency, that's what we used. For my practice, I use the posterior approach. I think it works better, and the dislocation rate is certainly comparable or less than some of those who use the anterior approach. The anterior lateral approach leaves people with greater trochanteric pain because you're actually stripping the muscles off of that. So there's different approaches. Many approaches came about where people tried to go smaller and smaller and operate through keyholes, single incision, 2 incision. The complication rate on those was fairly high because of lack of visualization. It was almost 10 to 14%, malalignment compared to when you can see what you're doing. So that's the thing to discuss with your surgeon as to what approach is used. I think there's advantages and disadvantages to both. There is a learning curve to everyone. You certainly don't want to be the first person that orthopedic surgeon does an anterior approach on. If he's done posterior approach for 20 years, you're probably better off going posterior approach than you are anterior approach, if that answers your question.
On a total knee replacement, as the slide said, the numbness and the heaviness in the knee, how long does that last?
Well, I think that everyone's a little different about that. You can have some numbness from the skin incision. That numbness is, those are the little sensory nerves in the skin, and that's generally what patients either complain about or notice after surgery. And that can diminish rapidly, and then to a point where it's very tolerable, and then they may have a little numbness. Some patients never complain of numbness, and some complain of numbness that can last up to a year or two, but generally that goes away. It doesn't seem to affect any of their activities of daily living. So like the things that you do on a daily basis aren't affected by that. It's not dramatic, heavy numbness. And the weight of the prosthesis, when I show my patients what the knee replacement looks like, they feel like, wow, this is heavy, but it's not, your body never really, very much, your body generally adjusts to the extra, like the weight in the knee. It's not something that you feel like you're lugging around.
6 to 8 ounces, I think, is
Yeah.
sort of the average weight.
Total hip replacement. You leave here and you're doing the therapy and everything, you have your follow-ups, but how long would you say on average before you're good enough, before you're not going to worry about falling down, before you can walk, and then you go to a car again? What do you talk about in downtime?
And most people are driving somewhere between 2 to 6 weeks. And a lot of that depends on what car they have. You know, if it's a car where they go straight across, that's a different story than if it's a car where they sit down into it and have to get themselves up.
Like a pillow there for yourself.
Yeah, I mean, it's not getting down because gravity certainly helps you down. It's being able to push yourself up with both knee and, you know, hip that's an issue. You're pretty independent when you leave. You've done stairs. You know, you're able to put full weight on it. You know, you're sore from the incision, but not really debilitating.
So left hip driving would be easier and quicker because you're
Yeah, yeah,
It's amazing. So, I mean, there's a lot of variation. Some patients are driving in, 7 to 10 days, and some are driving in, 6 to 8 weeks. It just depends on that strength of the patient, their kind of desire to move along with certain things, whether they have a ride or not, that type of thing. It's a lot of it is individualized.
yeah. And we've done hips in people as young as 40 and as old as mid-90s. So a lot of it depends on their, stated debilitation before their surgery too.
there's no
It's hard to
restrictions.
generalize.
You can try to do it if you can do it, basically.
Correct. And in most patients, your weight-bearing status is as you tolerate. So if you walk out with a walker or crutches and you come into the office with a cane, that's quite all right. And most people do use some assistive walking for 2 to 4 weeks, at least up to 4 weeks. They need at least carry a cane or something like that. And many walk quite nicely at 4 weeks without any assistance after hip replacement. Yes.
Would you tell us what the differences are in the types of anesthesia you use for knee replacement or hip replacement?
Oh, that's a very good question. Let me talk a little bit about knee replacement. And then in knee replacement, we definitely believe in regional anesthesia. What does that mean? Like not completely knocking you out, not putting a tube in your mouth, and rather keeping you sedated and comfortable, not knowing that the surgery is going on, and keeping you so that you're, just not aware of the surroundings, but not intubated with a full general anesthetic. We use regional anesthesia. What I mean by that is we use specific blocks, and we generally have a consensus on what blocks those are, but those blocks are to make your entire lower body numb for a very short period, completely numb for about 4 hours. But when that numbness wears off, you still have at least a good sensory block, so you don't have any significant pain during those first day or two. And we think that's critical in terms of your rehabilitation. So by breaking that initial cycle of pain and giving you that sense of comfort, it just helps those first 2 or 3 days of your initial rehab. So that you are confident with your knee, comfortable that you have, you're going to have a pain-free knee and a relatively reproducible rehabilitation process. And so we use regional anesthesia. We can use regional anesthesia. Do you want to talk a little about hip?
Well, just the other thing is that you do have a catheter in the groin that stays in there for the first several days, which you can give yourself your own medication. So that's certainly an adjuvant. It gets rid of a lot of that anterior pain. And for hips, same concept. You're much safer breathing on your own than you are having something else breathing for you. Much less chance of being sick. So by doing the spinal or the epidural, and again, a lot of that is back dependent. If somebody's had 6 back surgeries, they have metal rods up and down the spine, that's not going to be an option. Most people you're able to do the regional blocks in, sciatic nerve block and the epidural or spinal, and that's what we do for hips as well.
And I think regional anesthesia for both the hip and knee is very helpful to Rob, who does the physical therapy in post-op day 1, because that patient's more awake, more aware of his surroundings, and for the nursing staff to assess, their pain and so forth.
Yeah. Less narcotics, less chance of being sick, less chance of getting goofy, seeing things, better chance you can get up and eat and you know, get back to normal activities quicker. Yes.
Dr. Weiss, what are the pre-op conditions before you could actually operate on a person to replace the hip? What are requirements from their internal physician, and how many times would you have to see that person before you were able to operate on that person?
We want people to be as healthy as possible. I mean, and no surprises. So typically what we do, we get medical clearance and/or cardiac clearance. If someone hasn't had a stress test within the last year or 2 years, we typically get, you know, cardiac clearance and get a stress test. Most of the time it's a non-exercise stress test, a thallium stress test, because obviously if they have a hip or knee that warrants surgery, they're not going to be able to go on a treadmill and do an exercise stress test. The family doctors, we work intimately with them. They review all the blood work. They, you know, nobody knows the patient better than their own family doctor, and we make sure that their clearance is there and that everything is tuned up, that there's no urinary tract infections, that the person's in the best shape possible. So those are the clearances that we get. If there's any question, we get an anesthesia clearance as well. If there's any issues, i.e. previous back problems or history of nausea or somebody being sick or having difficulty with a prior anesthesia, we'll get an anesthesia consult as well.
I've heard a lot of controversy about double knee replacements, but if you've got a patient, you're having a bad day, you don't know which knee to lift on. How do you feel about that?
That's a very good question. I mean, I've got to get well quickly society. Oh, there's a lot of patients that come to me and ask me about having both their knees done, and generally I steer them to doing one at a time, because there is, for a number of reasons. One is it's a lot of surgery, and even if it's 1 hour or per knee, it's still, those patients are going through a much different rehab than the patients who have one knee done at a time. And I've done them as close as 3 months apart, actually. It is 2 rehabs. It's 2 recoveries. I think the other thing that is, there's a slight increase with a bilateral knee replacement with pulmonary embolism, which is something we really want to avoid. And so, with that in mind, I am only doing knee replacement bilaterally on patients who are so dramatically deformed that they need both done at the time, or they couldn't rehab properly. And you'll get different opinions. There's a guy out in Indiana that if you come in with 2 knees, he'll do 2 knee replacements right away. And I just feel like that there has to be some careful consideration about that procedure. So unless there's some really, really dramatic reason for me to do both at the same time, I will stage them.
I would say that it increases your complication rate from about 1 to 2% to about 10%. And the rationale for that is you have twice as much blood loss. So most people, if you have 1 knee replacement, rarely do you need a transfusion. If you have both, even though the blood is filtered, washed, and given back, you get about 60% of it back, and oftentimes you need a unit. There's about a 10% complication rate with any transfusion. You have twice as much pain, so you have twice as much narcotics on board. That in and of itself can cause confusion. It'll decrease your breathing, your risk of pneumonia increases, your risk of blood clots increases because you don't mobilize quite as quickly. There's a lot of things that people think about, or don't think about, I guess I should say, that goes along with bilateral knee replacements that you don't encounter if you just do one at a time. So it's certainly safer. I tell people that I'm not a big gambler, that you have 98%, 98, 99% success rate if you do one at a time. You have about a 90% success rate if you do both at the same time. Your decision. Saying that, 90% of the people who have bilateral knee replacements do well, but it's a 10% increase in complication rate.
I would say when you have 2 knees done, it's not twice as hard. It's like 50 times as hard initially. But then the initial rehab is a lot tougher, and then it gets easier as it goes along, and then obviously you don't have to have a second surgery. So
I think anecdotally as a group we've done very well with our bilaterals, the ones we've done at the same time, but they definitely are more anemic postoperatively, and the potential for complication rate is certainly high.
Does it depend on your weight, if you're going to do it or not?
Well, that's a good question. There are some doctors that will tell you to lose weight. And this is an interesting statistic. I mean, people after knee replacement don't necessarily lose weight. Okay, so or hip replacement for that matter. But in an ideal situation, you'd like to lose some weight. It definitely takes stress off your knee and may really make you feel better. And some people who've had weight loss don't need knee replacement after a significant weight loss. There's no question about that. But I really have had a hard time getting weight off my patients preoperatively. It's just not the easiest thing, and I'm a realist about that. So and there's been some very good data to support that that people who are a little overweight do pretty well after knee replacement. I think the complication rate, the risk of infection goes up a little bit, and that's for something that you would be aware about that I discuss with my patients. But I don't tell them that they can't have a knee replacement because they're overweight.
Okay. Is there a good, better, best in all products?
I tell everybody it's a little bit like, you know, Toyota, Ford, Chevy. Everybody feels really strong about what they use, and with good reason. And there's some advantages and some disadvantages with both. I think if they're put in right, all of them work well. As I say, I think everybody uses the components that they use for specific reasons. But they all work.
And there's a lot of marketing going on. Frankly, I say buyer beware a little bit. I'd really, if there's anything you can take out, if you're considering a hip or knee replacement, be comfortable with your surgeon. Be comfortable with him. It's more important than exactly what knee or hip he's putting in, because he's going to make that decision for you. He really will.
Thank you. I'm 48 years old, and I'm an avid hiker. I hike 1,000 to 2,000 miles a year. And I was diagnosed with a defect in my lateral trochlear, which is 3 centimeters by 1.5 centimeters. And then I was also diagnosed with my femoral condyle being 2 by 1.5, and the tibial plateau being 1 by 1. Now, I was a candidate for the De Novo NT juvenile cartilage implantation, which I recently, 8 weeks post-op. During that surgery, it was suggested that I have an osteotomy done to correct the alignment. Now, my question that I have is, one, what's your general opinion on it? And two, if you were to do it, what complications would result at the time that I'm going to need a knee replacement? Will you be able to put the devices in? Does it limit what you can use? Like you have the modern way we did it before you used to use the rods. What does that do to your chances if you decide to go to do that?
That's a great question. It's a very complicated question, but I'm going to just summarize briefly. You had a cartilage replacing procedure, so you're in that small group of patients who is having, but because and we can put cartilage back in knees, it's the actual alignment issue that makes the cartilage be removed again. So I think that the osteotomy makes sense if someone went through a de novo procedure as you described, because you're changing the alignment back to something more anatomic than that bowed knee you might have right now. Okay. So an osteotomy makes sense with a de novo procedure, but there's so few of these done today that you want to have that procedure done. There's really no data that supports that your knee's going to be any better now with this double procedure than it was before you had any of this done. Okay, right. So it's a very, very experimental group.
But does it limit, when I need a knee replacement?
Let's go back to then I'm going to do it. And there has been data. Talk about it.
It takes you from having a primary knee replacement to a revision replacement, basically. All right, it's much more difficult. There's a lot more scarring. There's a lot more bony deformity. Typically, you have to use a stem instead of a surface replacement. It's technically more difficult, and as I say, the best thing I can tell you is that it takes you from doing a primary total knee to a revision total knee.
But it doesn't remove the option, I guess.
No, not at all. In fact, there used to be many osteotomies done in the 70s and early 80s. Okay, many more than we do today, because we're using these half-knee replacements and we're doing other types of cartilage. And there has been data that said that those patients did not do quite as well as those patients who never had an osteotomy and went on to just a primary total knee replacement. There's been some data to support that group doesn't do quite as well. But I've had many a good number of osteotomy patients, as Dr. Weiss has too, that have done very well with knee replacement.
Say if you haven't had an osteotomy and a primary knee replacement, you should get us on a pain scale and function scale of 93, 94 out of 100. If you've had an osteotomy, you're down probably 87, 86, 87, something like that. So it changes things.
The risk benefit? Is there a risk benefit? I mean, like, does it give you 10 years, 3 years? I mean, is there any studies on?
Depends how much wear there is to start with. You know, it depends where your mechanical axis. Sometimes you can't shift the mechanical axis enough without you looking like you're walking like a duck. You know what I mean?
Okay.
You can't make somebody so knock-kneed to shift that mechanical axis over. So it really depends on your intrinsic anatomy. And you need to get long leg films to see what your mechanical axis is and where
Yeah, I
it,
think I'm 3%.
where it lies right now. So
And I don't know if that's great or not.
No,
if 23 degrees is bad
Not
so
terrible.
much.
Okay. Thank you.
Thank you.
We live in a fast-paced, on-demand world where everything is available at a moment's notice. Now your healthcare can be on demand as well. Coordinated Health, the name you trust for superior care, now offers Care on Demand, where you can walk in, no appointment necessary, and receive immediate care for all non-life-threatening emergencies. With specialists in primary care, orthopedics, cardiology, and women's health, and locations throughout the Lehigh Valley and Poconos, quality care is never out of reach. Coordinated Health, your prescription for better health.